Okay, so good morning everyone. Today we will continue with our journal club presentations. Today we have very interesting subject and very important one about the radiological manifestations of extra-pulmonary tuberculosis, and it will be presented by Dr. Sousan. تفضل دكتور. Just space.
Good morning. Our subject is about extra-pulmonary tuberculosis. Caused by the Bacillus mycobacterium TB, and it found in 2070 10 million people has been infected with TB. 14% of them is has the extrapulmonary TB, and we have divided two systems. We have lymphatic TB, and this is presented with most commonly by the cervical lymphadenitis, and any painless bilateral painless cervical lymphadenitis, we should think about the TB. And there will be the presence of necrosis in this lymph node will increase the probability of the tuberculous infection. This is about the tubercular lymphadenitis. It started by involving the lymph node. There will be a process of lymphadenitis, then matting together, and then there will be developing of cold abscess. There will be causation, and the cold abscess develops. Sometimes there will be subcutaneous collection, and this is called collar stud abscess. And sometimes there will be sinus formation. There will be the abscess will burst to outside. About the presentation of this cervical lymphadenitis on CT, we have four presentations: either multispatial enlarged lymph node with thick peripheral enhancement, or large low attenuation confluent masses with peripheral enhancement and loss of fat gland. The other types also have either homogeneously large lymph node without enhancement, or there is enlarged lymph node with thin peripheral enhancement but preservation of the fat plan. But the first and the second is more specific for the TB, because it is changing the multiple necrotic lymph node, infected lymph node, to a large necrotic mass. This is about as you see in this CT, this is a spatial hypoattenuating mass. This is a lymph node and necrotic lymph node. This is also a CT showing necrotic lymph node with central low density and extensive also mediastinal lymph node enlargement. This was about the lymphatic. We have about the central nervous system TB. The central nervous system TB will be manifested as most commonly by meningitis. There's also other causes. Tuberculoma may cause tuberculoma, may cause spinal TB, may cause abscess, and may cause vasculitis, myelitis, encephalitis, and calvarial tuberculosis. But before we go to this, I forget to mention that the first line for investigation, it is ultrasound by the gray skull, and to differentiate it from the metastatic papillary thyroid cancer, or head and neck squamous cancer involving causing lymph node enlargement, we can do a Doppler. In Doppler, we will have in TB there will be there will be low resistive intranodal vascularity, and there will be central vascularity, this is, we can differentiate it from the metastatic, that will be the peripheral hypervascularity.
So in TB, the vascularity is central.
Central, single central, and low resistive.
While in malignancy?
Malignancy, there will be high peripheral vascular.
Yeah, the resistance, both of them are low.
Yeah. Okay, about the we have this tuberculous leptomeningitis. This the caseating material will cause meningeal enhancement, especially in basal cistern, and as we see here in contrast, and that CNS infection is more common in those who have immune suppressed. This is also a case of TB or meningitis. This is hyper-enhancement of the meninges in basal cistern. The features either it is meningeal enhancement, which is the most common feature, or the caseating material will cause obstruction of the CSF pathway in the foramen of Monro or the fourth ventricle, causing this hydrocephalus or the dilated lateral ventricles, and may also causing infarction, as we see in following sessions. This is also the meningeal enhancement in the basal cistern and with dilated lateral ventricle, and there is also hyper-enhancement because of the edema from the obstructive...
This is not enhancement, this is called increased transependymal flow. It indicates active hydrocephalus, obstruction.
Okay. Not from because of the obstructive hydrocephalus?
Yeah, this is the obstructive hydrocephalus, active hydrocephalus.
Yes.
This is T2, clear.
Okay. This is also, we have leptomeningeal and this enhancement, and there's also infarction, as we see in the diffusion, hyperintense, and this is hypointense in ADC. This is all caused by the meningitis. The second feature, there will be tuberculoma. The second feature of the TB involvement, tuberculoma, and the tuberculoma has three type of tuberculoma. Either we have non-caseating tuberculoma. It will be like this small nodule, which is homogeneous enhancement. It's low in T1 and high in T2 and homogeneous enhancement. Or we have the second time is caseating, but with central, solid center. This is the second type of tuberculoma, and this you see it is hypo and or iso in T2, but when there is contrast, we give a contrast, we will see ring enhancement. And the third type is the caseating of the tuberculoma, and see hypointense and peripheral edema, and when we give contrast, there will be ring enhancement. This also, this is a CT. We see either it's single or matted ring enhancing lesion. These are all tuberculoma. This is also tuberculoma, as we see, and it has restricted in ADC. These are also about, this is about the leptomeningeal enhancement and the different types of the tuberculoma, and also the nodular, there's nodular leptomeningeal enhancement. In MRS, the tuberculoma will have lipid peak, and this is maybe we can differentiate it from the pyogenic abscess. This when the abscess developed, the tuberculoma, if more than 3 cm, it's become tuberculous abscess, and this we should differentiate it from the pyogenic abscess. This is also tuberculous abscess. We have ring enhancement with restricted diffusion, and the differentiation between the tuberculous and pyogenic abscess, the MRS will be elevated lipid peak, but the MRS of the pyogenic abscess will be elevated amino acid peak, and also the edema about the vasogenic pyogenic abscess will be more. These are type of the pyogenic edema. There is edema about, around it with ring enhancement.
With pyogenic or tuberculosis?
The pyogenic.
Pyogenic, okay.
Yes. Ring enhancement and restricted. Other feature is encephalitis. We see abnormal signal in the white matter, and there will be in T1 enhanced, there is nodular enhancement or in the white matter. This is a type of encephalitis. maybe calvarium involvement. In calvarium, this is epidural collection and subgallial soft tissue lesion, but when we come, there will be bone destruction. This is the type of calvarial TB. This is also calvarial TB, as in seen. This is parietal region. There's thickening and epidural collection, and when in the flare it is hypodense, but when give contrast there will be homogeneous enhancement. Spinal TB. Spinal TB after maybe it's hematogenous or after the brain involvement, there will be spinal TB. This is also this, the subarachnoid space exudate will be cut the spinal cord, and it's seen as a thick meninges covering the TB. The cord, and also maybe intra causing focal density in the spine. Either this is myelination or due to infarction, because it was caused by it. These all are also there is hyperdensity and hyperintensity, and there is enhancement, and this is the enhancement. This is also the same. This is acute, she has acute paralysis and hyperintense signal and enhancement. The spinal cord, with the infarction, with meningeal enhancement, we have also may develop, because of the chronic arachnoiditis, there may have syrinx development because of the obstruction of the CSF flow. About the genitourinary system, we have renal TB. This is also common in our locality. The first involvement will be in the minor calyces. There will be erosion and papillary necrosis, and leading to calictasis and moth-eaten appearance, and there will be also cortical granuloma formation, which either it's burst to outside and causing abscess form causation and abscess formation, or causing cavitation. And this abscess either bursts to outside to retroperitoneum, or it's bursted to the infundibulum. And at the end stage of the TB, the renal will be shrink and decrease in size, autonephrectomy, not functioning, no excreting of contrast, and containing dystrophic calcification. And this is involvement about the renal. And about the ureter will see mural thickening and stenosis and stricture formation. This stenosis may be at the pugae or at the lower ureter or in multiple sites, and giving this beaded appearance of the ureter. After the bladder will be involved. The bladder causes the wall thickening and with bladder wall calcification and decrease in capacity. This decrease in capacity is important to differentiate it from schistosomiasis. These are moth-eaten appearance of the contrast CT. This is plain. This is a calcification, and in the IVU there is excretion in the left side, but the right side there is cavity formation where that is burst into the infundibulum. This also hypovascular mass. This is tuberculoma with spot of calcification, and it is isodense in MRI and isointense in T1, and in T2 it is hypointense. Patients with miliary TB, pulmonary miliary TB, developing calyceal abscess and the bladder with rim enhancement, and the bladder is irregular, thickened with calcification. This is involvement of the urinary bladder, decreased volume and irregularity in the wall, and there will be the ureter stenosis at the lower ureter, causing dilatation proximal to it. This is wall thickening, vesical TB causing wall thickening. About the genitalia, male genitalia, the prostate and the epididymis is the most common site for involving of the TB, and it appears like abscess. This is a CT hypoattenuating nodular mass with rim enhancement in the prostate. This is TB. Okay, about the MRI of the prostate, you see there is a small nodular area in transitional zone, and when we do ADC, there is restriction about this, and there is a peripheral enhancement, and these patients will have elevated PSA, prostatic antigen. To differentiate, may be difficult to differentiate it from the cancer, but the restriction will be not so much like the cancer, and even the enhancement will be not like the prostatic cancer. This is epididymis, hematogenous enlargement of the epididymis because of the TB, and this is large abscess in the scrotum causing scrotal wall enhancement. About the female genital TB, most of the patients will present it with infertility, and there will be involvement of fallopian tube. The fallopian tube will be enlarged, thickened wall, enlarged, hydrosalpinx, biosalpinx, and scarring of stenosis. And we have the uterus, the uterine wall, the endometrium filled with heterogeneous material and thickened wall. This is also about the fallopian tubes containing hypoattenuating pus, biosalpinx, and the urinary bladder is thickened wall. And uterus, the urinary bladder, the uterus, you are right. Uterus is thickened wall, even the transitional zone thickened, containing the heterogeneous material. This is the hysterosalpingiograph, and this is the diverticular-like pouching caused by the TB. These all cause infertility in the female. About abdominal TB. Abdominal TB, the TB in abdomen is mostly, the spread is hematogenous, and the mostly involvement area is the terminal ileum. And presence of wall thickening, wall hyperattenuating thickening of the terminal ileum, ileocecal or cecum with necrotic lymph node. This is high probability of abdominal TB. This is also necrotic lymph node, as we see, and mesenteric necrotic lymph node, and the appendix. Their appendix will be mucosal hyperenhancement with wall thickening. This is barium enema. We will see the thickening in the wall of the terminal ileum, and there was reflex of the contrast to the terminal ileum. That means incompetent ileocecal valve.
هذا يسموه cecal amputation.
Cecal amputation, retracted cecum.
Like someone cut it.
Yeah, because of the stenosis and fibrosis.
Fibrosis, abnormal shape,
yes.
shrunken.
Yes. Okay, this also we have thickened hyper-enhancing terminal ileum, and in the axial view, this is a terminal ileum hyper-enhancing, and in axial view, this is a target sign or halo appearance of the tuberculosis. Okay. We should differentiate the TB from the Crohn's disease, and these are some features that suggestive of TB, involvement of ileum rather than cecum. If you have no skip lesion, and you have no mural stratification, you have no fistula, sinus tract, and we have the Crohn's disease will be more about increased mesenteric vascularity, the COM sign. But the TB will cause more intestinal obstruction and perforation. As we see here, this is a Crohn's disease. There is a thickening in the wall, and we see this increase in hypervascularity in this COM sign. Yeah, this is about Crohn's disease.
And by the way, previously they thought that TB of the ileocecal valve is the same as Crohn's.
Yeah.
Yes.
Some difference. There are
then
some.
they found there are two different diseases.
Yes. These are some chart differentiated between them. The important that Crohn's disease will cause more abscess, but the tuberculosis more causing ascites, high density ascites. This also Crohn's disease. We have this hyper enhancing terminal ileum with hypoattenuating and rim enhancing, and this causing abscess formation that open to the anterior abdominal wall. Yes, this also Crohn's disease. Okay, about the peritoneal and mesenteric TB. Peritoneum TB will presented in three features, either it's wet type or dry type or fibrotic type. And okay, this is the wet type. There will be ascites formation and thickening of the enhanced. There will be thickening in the peritoneal wall, and the ascites will be hyperattenuating. Okay, this is also pleural TB, their consolidation, lung consolidation, pleural effusion, and ascites. This is also like omental cake. This omental thickening and multiple enlarged mesenteric lymph node.
So this is the dry type, right?
Yes. This is adrenal. Okay. We have solid organ involvement. Solid organ involvement, we have adrenal gland. It causes mass-like lesion with necrotic inside. It's usually bilateral, and at the end stage, it will be causing calcification like that. This is bilateral, and there is at the end stage, it will be calcified.
And this will cause adrenal insufficiency, right?
Yes.
At the end, they have adrenal insufficiency.
Yes. Also, that the liver and spleen will have either macronodular involvement or micronodular involvement. This is non-contrast. We see this rounded calcification as we see, and this is after enhancement. There is some sort of edema surrounded it, and this is the liver face that we see it, and this is multiple granuloma of the spleen. Musculoskeletal, we have spondylitis. The mycobacterium reach the spinal through the hematogenous secrete and infect the central and the anterior portion of the vertebral body. It will cause intraosseous colon abscess and vertebral destruction. Like this. This is the vertebra, axial section. This is the abscess with rim enhancing and paraspinal abscess. There will be vertebral destruction. This is the vertebral destruction, and some sort of the kyphotic angle, and as you see in plane and in the
somewhat gibbous
deformity. This is also spondylodiscitis because of the TB, and there is hypo-enhancing lesion distracting the vertebra and pressing on the spinal cord. This also, there is in two level. The features of the TB of the spondylitis, it's multi-level and associated with abscess. The abscess is ligamental in the anterior, with the wall of the abscess will be thin and enhancing thin wall.
See here, this level involved, and between them are spared.
Yeah.
Why? Because it spreads in a subligamentous level.
starting from here all the way to here.
Yes.
These are spared, then involved, then spared, then involved. So this is typical for
TB.
subligamentous spread of
Yeah.
TB.
This is also different. We should differentiate it from the pyogenic spondylitis. The pyogenic spondylitis more will cause the destruction. This is it. The pyogenic will be more involvement of the intervertebral disc, as we see here, and the abscesses formation will be the thick wall like that. This is abscess formation, and in enhancing, it will be thick, irregular wall of enhancement. We should differentiate it from the metastasis and from the brucellosis also. This is brucellosis spondylitis. It will has minimum no destruction. The vertebral body preserve its picture. This is also about metastasis. The metastasis more involving the posterior element of the vertebra, and as we see here, causing paraspinal mass and posterior element involvement. And this is enhancing on contrast study. Tuberculous arthritis, the tuberculous involving the joint, most commonly hip and knee joint, it will cause, as we see in the plain X-ray, after a period, this 3 months and the 5 months, there will be periosteal, yes, joint space narrowing, osteopenia, and erosion, yes. This also, there is effusion with bone erosion and synovial enhancement. This is the synovial enhancement. This is all about the one patient, and this is synovial enhancement, and this is after 1 year treatment of the anti-TB. This only remain the synovial thickening. There is disappearance of the effusion. There is also involvement of the tuberculous osteomyelitis involving the bone, this more occur in children, and as we see, there will be edema, intraosseous abscess formation, that with cortical defect involving the capsule, and as we see here, there's cortical defect. We have also subcutaneous TB, and we have intramuscular TB. This is about, has been injected, gluteal lipo injection, and by the contaminated syringe, developing these micro abscesses. This, you see, in the stair will have edema surrounding it. And this is also intramuscular with mediastinal involvement TB. It can extend it to the pectoral muscle and causing abscesses in the muscle. This is also one feature of the one feature of the TB, that it causes intramuscular abscesses. This is also hip joint, and this is the abscess of.
Thank you very much. Very nice overview of the entire extra-pulmonary TB. So you can see that anything can be TB. It can involve any part: skin, muscle, bone, liver, spleen, everything, kidney, peritoneal, and of course lungs. So keep TB in mind. TB is always there. And by the way, in our locality, brucellosis is also common. Brucellosis of the spine is very difficult to differentiate from TB of the spine. So usually, all of these cases are biopsy proven. At the end, you have differential diagnosis. You can't say, well, this is TB not metastatic because it has modified sign or this. At the end, you just suggest the diagnosis and hope you are right.